So the APACT trial was a large phase 3 trial in the adjuvant setting. Patients who had resected disease, could be R0 or could be R1 resection. Patients who fulfilled the entry criteria, one of them was to have a low elevated CA19-9 level, well recovered from the surgery. They were randomized to receive either the combination of gemcitabine plus nab-paclitaxel, or they would receive gemcitabine, which has been the standard for a while. In this phase 3 trial, most of the patients had lymph node involvement, and the percentage of patients who had an R0 resection was 40%. This study showed that the primary endpoint, the progression-free survival, based on the independent review, was not improved. So that was one finding. Primary endpoint, investigator sending the information to the independent review, that did not show a benefit of adding the combination nab-paclitaxel to the gemcitabine. However, when they went back and looked at the investigator, this is investigator's decision on disease progression, and they looked at the numbers there was certainly a benefit in the combination versus the single agent. The other important point about this trial is that the survival, which, it's black and white, either alive or dead, there's no investigator or independent review, that showed a statistically significant improvement in the combination. The difference wasn't huge, it was less than 5 months or so, but still it added a benefit to gemcitabine alone. But overall survival was a secondary endpoint. It was not a primary endpoint. But still, you cannot dodge the numbers. It showed improvement. So at this point in time, we learned several things. One of them was the progression-free survival, or labeling someone who's progressing after receiving adjuvant treatment or what is adjuvant treatment. There's a discrepancy between an investigator-based assessment and independent review. And that's understandable because the independent will get the scans and reviews them, but the investigator who's treating the patient knows much more about the patient. They know about their CA19-9 or their symptoms. So that's something which really, at this point in time, is a bit of a concern. How do we really do independent review of those patients and try to make a decision whether they're progressing or not? But nevertheless, the study was written this way, and the primary endpoint did not meet its significance. But going back into the overall aspect of the trial, is it really going to affect our daily practice in this disease? Well, we know that modified FOLFIRINOX in well-selected patients, healthy patients, works. In fact, it works very well. The hazard ratio is close to 0.5, so it's a very effective treatment, although we're waiting a bit more on the mature data in terms of survival. However, FOLFIRINOX, you can't give it to everyone. FOLFIRINOX still has side effects, toxicity, especially in someone who has had a major surgery like pancreatic surgery. So the question is, are we going to consider the APACT trial in terms of treating some patients in the adjuvant setting? And the answer is yes, because if I have a patient who I don't think they can get FOLFIRINOX, or they will start on FOLFIRINOX and they have a lot of GI toxicity, then I think in that situation it's very acceptable to consider gemcitabine nab-paclitaxel as the alternative regimen. Of course, you have the other alternative, which will be to use gemcitabine alone. But we know for survival the combination is statistically better than gemcitabine alone. So it's hard to really not justify or do against the combination of the gemcitabine nab-paclitaxel in a patient who we cannot give the FOLFIRINOX to them.